Hello and welcome to the State Peer-to-Peer Learning Facilitating Care Across the Crisis Continuum Children's Services. Please note this meeting is being recorded. All participants are currently muted. You may submit questions and comments into the chat box throughout the meeting. We encourage you to view the meeting in speaker view to easily view the presenters by changing your view in the top right-hand corner of your screen. Closed captions can be accessed during the meeting by clicking on the closed caption icon at the bottom of your screen. And I will now turn the call over to David Viller with NASHBID.
Thank you, Bailey. Welcome, everybody. Excited to have you here. I'm very excited to introduce Dr. Belina Shaw, who serves as Senior Medical Advisor and the Center for Mental Health Services Liaison to the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA. She is a triple board certified psychiatrist in the specialties of general adult psychiatry, child and adolescent psychiatry, and addiction medicine. Prior to joining CMHS, Dr. Shaw was the medical director for the Behavioral Health Division of the Prince George's County, Maryland Health Department. She is a graduate of Yale University, the Johns Hopkins Bloomberg School of Public Health, and the University of Pittsburgh School of Medicine. Dr. Shaw, I will turn it over to you for a welcome.
Thanks so much, David. Am I unmuted now?
Yes.
Okay, sounds good. I think we were unmuting and muting ourselves simultaneously. So thanks again to NASHBID for putting on another very exciting series. I am very excited about the second of 4 of the SAMHSA-sponsored quarterly learning series or sessions. The focus of today's session will be on the development of specialized crisis interventions for children and their families to help address their crisis while avoiding the use of emergency departments and inpatient hospitalizations whenever possible. I'll note that the most commonly or the most frequently watched Crisis Jam episode, if you guys are aware of the weekly Crisis Jam, it happens on Wednesdays at noon. And the most commonly watched one, the top one, has been the one that Dr. Everett and I did on youth crisis services, the special youth crisis guidelines. I would not necessarily say that it's because we're that special, but I think it's because really this topic is so salient and important to the field and really to the needs of our nation's youth in the midst of a youth mental health crisis. So today's session will feature the work of 3 states, Arizona, Connecticut, and Tennessee. And they've all developed their own specialized child and family-focused components of the SAMHSA national guidelines. And those guidelines, just to remind you, especially as written in the youth crisis guidelines, were someone to talk to, someone to respond, and a safe place to be. So one thing I just want to address here is that in these slides today, you'll see that the presentations are using a safe place to be as the third part of the components of the SAMHSA 3 components of a crisis system. And you'll probably remember that in the original 2020 national guidelines, it said a safe place to go. And in those guidelines that were developed a couple of years later that were specific to children, there was a language of a safe place to be. So, and that safe place to be had really evolved from the concept of the idea that children and families and youth and they should not be taken out of their homes as much as possible, whereas the other model has a little bit more emphasis on that facility-based care for that third component. And so, the language now, we say that it's not confusing, but it's evolved or it's iterative, but it is a tad confusing. This third component really now is a safe place for help, that in the way that we're conceptualizing it broadly at SAMHSA to really blend a safe place to go and a safe place to be, knowing that at home, least restrictive interventions are important for both adults and youth. But today, in today's presentations, you'll see a safe place to be, which harkens back to the youth-specific guidelines, and I thought that it was helpful in this context to maintain it. And just for also a note, that language has changed to someone to contact, knowing that youth also text and chat more often than adults to 988. So after I get over all the housekeeping related to the 3 components, a safe place to be, go, help, I just wanted to tell a little story because that's why I always like to do introductions. I used to do child mobile treatment. My sort of hashtag is I used to do medication management visits. Well, my butt might have been in the windshield, and I was looking at a kid in the back seat and doing the medication eval in the car and on the street, and sometimes looking at a drug deal happening out of the back of the corner of my eye behind the car. And that was really done so that we could make sure that we were keeping youth in their homes and in their families and their family units. So I love the presentations that you'll hear today because they're really going to focus on that stabilization component and really being able to wrap around youth in an intense way to keep them at home. So they'll focus on crisis receiving centers, but as well as the stabilization components in their homes. And you'll hear from each of these states about the importance of collaborating across systems as well to make sure that they're using the appropriate services. These states are working well with their schools, law enforcement, child welfare, Medicaid agencies, et cetera, and just to make sure that there's no wrong door for youth that are experiencing a crisis. And finally, all 3 states are working closely to support the families of children as a key component of helping to assist a child during a behavioral health crisis. Many of the other states participating in this learning session are also developing robust crisis services for their children and families in their respective states. And so after the 3 presentations, we'll have some time for other states to share their work and lessons learned in this important area and have some time without the camera and without the recording, just to have some frank peer-to-peer time between the presenters and each other. So I'll turn it back over to David Miller. I want to thank David and Megan and all the different NASHPD staff that are always working to keep our vision and mission alive here at SAMHSA. Thanks again.
Dr. Shaw, thank you so much. I'm very excited to introduce 6 incredible subject matter experts and presenters from Arizona, Connecticut, and Tennessee. Andrew Medina is a crisis administrator at the Arizona Healthcare Cost Containment System, and Dr. Margie Balfour is the Chief of Quality and Clinical Innovation at Connections Health Solutions in Arizona. Dr. Stephanie Bozak is the Behavioral Health Clinical Manager of the Children's Health at the Connecticut Department of Children and Families. And Dr. Frank Gregory is the Administrator for the Division of Behavioral Health Administration at the Connecticut Department of Children and Families. Jennifer Armstrong is the Director of the Office of Crisis Services and Suicide Prevention at the Tennessee Department of Mental Health and Substance Abuse Services. And Carrie Virgo is the Deputy Assistant Commissioner within the Division of Children and Youth Mental Health, also at the Tennessee Department of Mental Health and Substance Abuse Services. Welcome, everybody. We're so excited that you are here. We're anxiously awaiting your presentations, and I will turn it over to you, Andrew.
Perfect. Thank you, David. Really appreciate it. And Arizona just wants to start off by thanking everyone for the opportunity to really share space today. If we go to the next slide, please. So just quick level setting. In Arizona, we define crisis services as intensive, time limited, intended to stabilize or prevent potentially dangerous condition. And you'll see that that can be up to 24 or 72 hours. And just so individuals are aware, what really is the determining factor with that is if an individual is a Medicaid member or not. If they are not, then we do look up to 72 hours because we know more time and effort might be needed to collaborate with private insurances, or if an individual is not insured at all, then really look and figure out what resources and how we can connect them or what needs to be done in order to ensure that follow-up and that stabilization. Services in Arizona, respective of crisis services, are available to all individuals, adults and children, regardless of their Medicaid eligibility. And that even goes to individuals who might be visiting Arizona and have a crisis episode and need to utilize our systems. Our services are there for anyone. Crisis services are administered by our regional behavioral health agreements, which are managed care organizations that are responsible for crisis services in their respective geographical service area. And in Arizona, we have 3 geographical service areas. We have the North, the Central, and the South. And in Arizona, 15 counties broken up into the respective geographical service areas as appropriate. So that's just a quick level setting of what crisis services in Arizona look like and how we break it up in order to ensure, that service, that equity, that parity, and that we're really keeping eyes and ears on every Arizonan or any individual that needs crisis services in our state. Next slide, please. So quick overview, as I'm sure many of you are aware, this is Arizona's crisis continuum. And what we're really looking to do, to keep it short and sweet, is get the right work into the right hands and ensure that we can serve individuals in the least restrictive way possible, and as it's needed to them. So if any individual calls into our crisis line, or even if we are collaborating with 911 police and they call into our crisis line in order to, really make sure that we're getting that right work into the right hands, that we're decreasing, ED utilization, we're decreasing use and reliance upon the justice system. Arizona's crisis continuum is really designed to figure out and to triage and to get people at that appropriate level of care. So next slide, please. So in Arizona, we have 12 principles that guide, children's system of care and the delivery and the development of services. These 12 principles, which Arizona and Access and all our partners are committed to, really give us something to evaluate our services upon, or really consider when we're looking to develop and continue building out services for children, adolescents, and youth, making sure that we are utilizing best practices, that evidence-based, making sure that we are, facilitating stability so that there's a stability of even services that our children, family are utilizing, so they're not being bounced around from one place or another or one service to another, and having these 12 principles, which the document is linked, on the slide, really just gives us a general roadmap, gives us an opportunity to consider, are we making sure that our services are accessible? Are we making sure that there are, timeliness to the execution of these services? Are we making sure that we are empowering our children, our youth, and our families? So having these 12 guiding principles in the children's system of care has been something that Arizona has found very, very beneficial, in the development and the serving of everyone who may need these services. So next slide, please. So just a quick overview of Arizona services. When we're looking at that someone to talk to, of course, we have 988, the phone, the text, and their chat options. But in the state of Arizona, we also have Arizona's statewide crisis hotline, which also has a text and a chat component. And then we have the privilege of having our Arizona Teen Lifeline, which is a service that is staffed by adolescent teenage volunteers 15 to 19 years of age. And the hotline provides a safe way for teens to talk to other teens about thoughts of suicide, depression, anxiety, grades, family issues, really leveraging that peer component, because we know in the adolescent stages of development, it is very, very, my words escape me, but it is very normal to see that adolescents really do honor and value and do seek out their peers, and having that peer support. So in later slides, I'll go a little bit more in depth on that. And then as far as someone to respond, in Arizona, we have 104 GPS-enabled mobile crisis teams that operate across the state and that are capable of responding to youth and family, 24 hours a day, 7 days a week, 365 days a year, 366 leap year, which we just passed, the leap year this day. And then always for a safe place to be, we do have 4 youth-specific crisis stabilization units. And if you look at the map that is on the screen, 3 of them are currently in our central GSA. 1 of them is in our southern GSA, which we are very, happy and proud of that particular CS unit because of the wonderful work they do, which Dr. Balfour will go into later. And in slides that are up to come, you'll see that we're currently in the process of developing 2 more crisis stabilization units in northern Arizona, which will be located in Flagstaff and Kingman. So really just trying to ensure the parity of services, the access to services, and cover every nook and cranny of our state. So next slide, please. So this is the data slide, which kind of speaks to the why, the why we're doing this, what is the need? And in Arizona, this is looking at the months of October, November, and December of 2023. We averaged about 5,481 calls, chats, and texts from youth across the state. That represents a 10% increase from the same period last year. And of our total state crisis call volume, youth, adolescents, and their family represent about 13% of that volume. And the main reasons that we get for these calls are roughly around 40% because of SI, suicide ideation. Then we look at about another 23% for aggression, danger to others, and then about 13%, which is calling for social concerns. Going into the next, phase where we're looking at someone to respond, we average about 1,300 mobile crisis team dispatch across the state, which are youth and family oriented. About 25% of all mobile crisis team dispatches, in this period were for individuals under 18 years of age. And if you look at the numbers, you can see that while only 13% of the call volume is representing youth and adolescents, we have 25% of the dispatch volume, being represented by youth, adolescents, and their family. In Arizona, we do see that there is a greater need for that, in-person, that mobile response when it comes to our children, our youth, our families, our adolescents. And then on average, 21% of all mobile team dispatches result in a higher level of care, which once again is a little bit higher than when you look at the total volume of Arizona and like adults and what the adults look like when, going to a higher level of care because of mobile dispatch. When we're looking at that safe place to be, on average, we have about 1,200 youth that present across all CSUs each month in the state of Arizona. And these youth comprise approximately about 11% of all who present at our crisis stabilization units. Once again, that on average, 332 individuals under 18 were admitted to stabilization units each month. And of those, we were able to keep 74% of those, stabilized in their communities 90 days after the period. So this really just kind of gives that snapshot and gives that picture of why we are looking to develop, grow, and really serve this particular population. Next slide, please. So going back to the Arizona Teen Lifeline, it has been a crucial connection point of hope for our teens for over 37 years. Arizona has been blessed for the service. Peer counseling is available daily from 3 p.m. to 9 p.m., staffed by volunteers ages 15 to 19 that do have to undergo 72 hours of training to make sure that they are prepared to support their peers. And then outside of the peer counseling availability, this line is actually then handled and operated by our state vendor, who also does our 988, our 211, and our state crisis lines. So keeping that continuity of care, making sure that if anyone reaches out to this line, there's always someone there for them. And then crisis counselors who cover outside the peer hours, with our state vendor, they are required to have specialized training for the teen population. Next slide, please. And looking at current projects that Arizona is executing, this is the START project, which stands for Systemic Therapeutic Assessment, Resource, and Treatment. This is for individuals age 6 and up, and specifically those with intellectual and developmental disabilities. We are currently in the process of working with the University of New Hampshire on this. And, because when we were seeing the mobile dispatches that are happening within the state of Arizona, we saw that there really is an opportunity to strengthen the knowledge base and strengthen, what they're doing. So right now we are currently in the assessment phase with the Center of START Services at the University of New Hampshire. So we're getting the baseline data, and then we're figuring out, the implementation plan and next steps so that it can really serve the children, youth, and adolescents, specifically those that have that intellectual and that developmental disability, portion in their life. Next slide, please. So the other project that we are also engaging to strengthen our mobile response is our mobile response stabilization services. This is being done in partnership with the University of Connecticut, their School of Social Work. And this is specifically designed as an upstream intervention, that more intensive, that stronger wraparound to meet the needs of children, youth, and adults and their parents and caregiving systems. This is really about figuring out how we can intervene at the earliest points possible, how we can really wrap around services, and how we can be more intensive, especially at the mobile response point, so that we can mitigate those that are utilizing emergency rooms, those that are utilizing crisis stabilization units, and then having that strong follow-up, that wraparound that really ensures that they're engaged in those community services to support, the family, child, adolescent needs. So next slide, please. And then here, this is more about those youth crisis stabilization units that we're developing in the north. So we're expanding crisis observation services to children in the north part of the state where there is a current lack of child-specific stabilization facilities. We are leveraging ARPA funds to start the 2 stabilization facilities with on-site short-term crisis respite capacity and 2 intensive wraparound teams to work with children and families after their discharge. Facilities and teams to be established are in the Mojave and the Coconino County, more specifically in Flagstaff and in our Kingman area. So if you remember back to the map, those were the 2 most northern points where you had adult facilities, but we did not have any children specialized one. And then one of the great things to note about the Coconino CSU is they're expected to have lodging space to allow the family to stay on site with their child. So that way we know we're keeping, the child unit together, because their stabilization is in tandem with their caregiving system and their peers. And there are a lot of great CSU work happening within the state of Arizona. And we're really excited to get these up and running, which is expected to be in 2025. So one more year, and hopefully we'll be able to speak to a little bit of what we're seeing in these units. But at that point, and I will go ahead and pass it to Dr. Balford and proceed to the next slide, please.
Thanks. And like Andrew said, we have lots of children's services around Arizona, and I'm going to talk about our crisis stabilization center that's down in Tucson. And the CRC was built back in 2011. So we've been doing this. It's been open for over 10 years now. We've been there for just about 10 years at Connections, running that facility. And it was a community partnership that created it. It was built by the county using bond funds, but the services, I think it's important to note, the county didn't then have to figure out how to sustain this forever. They maintain the building, they lease it to the REBA, the Regional Behavioral Health Authority, which is contracts with Access to then contract with all of us sub-providers to provide the services. So all those funds are funded via the healthcare system that way, using a braided model of Medicaid funds, SAMHSA block grant funds, state and local funds. We see about 2,200 kids per year, along with 10,000 adults. So, it's a busy building. This graph here kind of shows where our kids come from. So most of them, come via walk-in, or their families bring them, or their group home brings them, or DCS brings them, followed by law enforcement, followed by mobile crisis. And then we get some transfers from emergency rooms as well. Next slide. These are some more numbers. So last year we had 2,154 visits. We have 2 levels of care. We have urgent care, like walk in and see someone, see a social worker, see a provider, and hopefully get them in and out in a couple hours. Then we have our observation unit. And if you look at both of those, all comers combined, the vast majority of people, 70% who come through our center, we're able to discharge them back to community-based care instead of sending them to a hospital or emergency room or jail. And 98% of our families say that they would recommend the CRC to others. If you look at, these are some trends we've noticed over the years. The ages, still the majority of who we see are adolescents, but that 8, 9, 10, 11, 12-year-old group has really been on the increase, especially in the last few years. And then substance use. The systems in Arizona are all integrated, so we can treat a mental health crisis, we can treat a substance use crisis, we can treat both. They're both considered primary, and we don't have to worry about a detox bed versus a crisis bed, et cetera. So about 28, over a quarter of our people have a substance use diagnosis or a positive tox screen. The vast majority of that is cannabis, but we are followed by alcohol, but we are, like everywhere, have been seeing opioids, increase over the years. Next slide. Because we get, a significant chunk of our kids come via law enforcement, we really where it's similar to, you may have heard with the adult models, it still holds true for kids, which is one of our core missions is to keep people out of jail. And it's law enforcement who brings people to jail. So we have this culture all throughout Arizona of treating law enforcement as a preferred customer to try to make it easy. And they get training on doing the right thing and connecting people to treatment, and they want to, but we have to make it easy for them. So we have a separate law enforcement entrance that does a couple things. It allows us to get the officers in and out as quick as possible. They have their own space so they can make a copy, use the computer, go to the restroom, have some refreshments without having to, take their guns off and things like that. And also it decreases stigma, because if you ask officers, they don't like bringing people through the waiting room, and it's awkward for them as well as stigmatizing for the youth. And none of the other youth now know who came via police versus who, came somewhere else. So it reduces that stigma. Also, we're very fortunate to have a very progressive police department with the Tucson Police. And they've changed over the last few years. They've changed their standard operating procedures to not have to handcuff people, which, I mean, I don't like anybody in mental health crisis having to be handcuffed, but kids, it's even worse. So, a lot of who we receive are not handcuffed, which is great. But if they are, it's our peer supports that unlock the handcuffs to send that message that you're here for treatment and not, not in custody. Next slide. This shows some of our, just how many drops we have. It's the purple ones are our youth, and then the greens are our adults, and then the blue dots are how fast the officers are in and out. And so that, making it easy for them to drop off is huge to getting them to not bring kids to juvenile detention. And that's what that no wrong door means. Be easier to use than jail, don't require medical clearance prior to drop off, and we never turn police away. And we take a lot of high acuity kids, people who are agitated and violent, and they can be intoxicated. And we do all that without using security guards, because our philosophy is our staff is receiving a huge amount of training. And so why would we default to somebody with less training to help manage someone who's agitated? We should be the experts in that. Next slide. And then I mentioned we had our urgent care. So that, they're able to get that assessment started within 25 minutes and that's our median time for that. That's open 24/7. So anyone can, bring their kid in, get seen, and then get connected to community resources. And then for those that are higher acuity, we have our 23-hour observation unit. And again, we're always trying to do that least restrictive care and get the person back into the community and the kid back with their family as much as possible. So we start with the assumption, so we don't consider it a holding to wait to find someone a psych bed somewhere. We are assuming that we're going to resolve that crisis, and then we work to do that with our interdisciplinary team that has social workers, peer supports, providers, nurses, and our behavioral health techs and our peers. And when we're doing groups and we're doing activities and peer and family support, I'm really trying to figure out what that person needs to get back into the community. It's an open area so that we can make sure that everyone is safe and that we have line of sight on everyone. We also have an outdoor patio area, which is where the chalk wall is. So you can see that's what one of our kids, the message they wrote there. And then the community partnerships are hugely important. So we have a lot of kids in DCS, which CPS custody. So we have a daily call with them because we know placement is such an issue. So we want to be proactive for things that over the years we've learned people can get stuck with, so that DCS placement is super important. We also have looked at what we call our familiar faces, people who are in crisis multiple times and do interagency staffings with the Regional Behavioral Health Authority and other health plans to figure out what we're going to do differently, how we can keep them out of crisis. Next slide. And this, I just want to kind of end with this, like one of the most important things we've learned over the years in doing this is that the crisis resolution, there's really two crises that you're working on. You're working on the youth's crisis. And so this red line shows, they come in acute crisis, and we can resolve that most of the time in that 23 hours. They're coming in, they're too acute to be sent to a group home, for example, or wherever they're at. says we can't manage them here, and they come in with us, and we could de-escalate that. Next slide. But what happens is the family is still in crisis. And you know, we're saying, okay, well, you know, they're doing a lot better now. We think they're ready to come home, and the family's like, oh no, like you know, they're still in crisis, and they're not able to take that kid back. And this really, next to the next thing, I forgot this was animated. But that when you have this mismatch, this really illustrates why doing this kind of work with your crisis stabilization units, the outcomes are going to be highly dependent on what are the resources in the community around you. You know, this doesn't work in a vacuum. And over the years, there's been kind of lower level crisis residential. When those are available, we are able to keep kids out of the hospital more. Or, you know, therapeutic foster care, when that's available, we can keep kids out of the hospital more. So over the years, we've seen, you know, various services come and go and come back again. But when you're designing your system, it's I think it's really cool the new crisis units that are being done that have that ability to keep the family together. But I think that just going forward it's really important to think about the whole system and not just your CSU like an island unto itself. And with that, to hand it over to Connecticut.
Thank you very much. I'm Frank Gregory from Connecticut. I'm joined by Dr. Stephanie Bozak.
Good afternoon, everyone.
Next slide. We're going to walk you through a little bit of our crisis continuum. And as has been referenced, the different pieces of this, someone to talk to, someone to respond, and then a safe place to be. And we recognize that even though this last place is outside the home, that the goal is to facilitate the youth's ability to be at home. So our whole system is geared toward providing the supports and services to enable them and their parents to be successful at home. And if they need to go out from home, it really is only when they need to, for as long as they need to. Next slide. So the system we're going to talk about does include those 3 levels of intervention, if you will. And we'll talk a little bit about the first 2 and spend a little bit more on the third, because that's the aspect of our system we've most recently built out. And this has come in response to a long progression of conversations and work going back to at least 2014, and certainly before that. But in 2014, we had the implementation of the Connecticut Children's Behavioral Health Plan, which was in response to the crisis in Newtown. And we had an extensive stakeholder involved self-assessment of the needs throughout the state. And one of the things that continued to come up was, as has been talked about in other contexts and states, the need for an alternative to having to rely on an emergency department when you're in a behavioral health crisis. And that really families needed somewhere else to be. Talking with families, they essentially said, we don't want to have to go to an emergency room. And when we do go to an emergency room, we want our experience there to be different. And so responsive to that, we have spent several years and a lot of resources building out our system of care, including expansion of mobile crisis services and creating alternatives, including our new urgent crisis centers and our soon-to-come subacute crisis stabilization units. Next slide, and Dr. Bozak, I think, is going to take us through some of this.
Absolutely. Thank you. So as Frank mentioned, we have expanded our someone to respond or someone to talk to or connect with. So as everyone knows, we have our 988, which is national now. And here in Connecticut, we actually have one contact center that handles both our 988 calls as well as our 211 calls. So for youth, if a parent or a school is calling, they can call 211, or they can access the same service through 988. And that has now been expanded for 24/7, 7 days a week, 365. And they can do, United Way, who DCF contracts with, is our call center, and they will be able to coordinate services with our mobile crisis. Next slide. So our mobile crisis has also been expanded for 24/7 as of January 2023, and they can provide face-to-face response at any hour of the day and meet the family where they're at. So a family can call 211. The mobile crisis will be deployed, and the goal will be to get to the family within 45 minutes. So family will call. That time starts at the moment that a family is connected to the United Way. They will then dispatch to the local mobile crisis unit, who will then be able to respond to that family where they're at. Since the expansion, we found that most of the new calls have occurred during the weekends. Last year, we've had about 12,000 calls that have been, nope, I'm wrong about that. Frank, help me out. 12,000? Yes. Okay. I'm looking at the number going, I think that's wrong. But we've had about 12,000 calls where mobile crisis has responded to the families. And again, 70% of the calls come from youth families, and about 23 comes from ED. And those are during those expanded hours. During the regular call hours, mostly our calls come from schools, which tends to be our highest referral source at about 46%, and families are the second highest at about 38%. Next slide. Then we have the somewhere safe to be. And as Frank mentioned, the goal here is really to provide an alternative to an emergency department. So urgent crisis centers, there is no appointment needed. It's almost like when we have an injury that doesn't require an emergency department, maybe it's a sprained ankle or a broken wrist, we go to an urgent care center, similar to what we have for that. We've created something that is an alternative in a different space for families that can truly meet the needs of mental health crises for youth. Next slide. So the goals of our Urgent Crisis Center are to receive youth and young adults ages 0 through 18 who are experiencing a behavioral health crisis. This can be through a via walk-in, and we are working on both police and ambulance drop-off. Once there, their youth would be triaged based on the risk and the needs of that particular youth. The UCC Center can provide de-escalation and crisis stabilization services and offer a thorough assessment to really make the appropriate level of care recommendations, and then connect that family to what the next level of care should be and make those referrals. The nice difference too regarding the UCC is that they also offer a bridging service. So it's not just that the family is going to be handed a referral and sent on their way. What they do is they offer that bridging and aftercare to really meet with that family until the connection to the next service is really made available. Next slide. The teams are multidisciplinary. So at our urgent crisis centers, youth and families are met with psychiatrists, nurses, mental health clinicians, discharge planners, family navigators, behavioral specialists, and administrative support. And the reason for this is to really wrap the family around with a really holistic approach. We really wanted to encourage that peer connection, and those family navigators are able to meet with that family and walk through the system with them and make recommendations into the community as well and make those connections. Our UCC centers that DCF has contracted with are located in the community, and they've made some really good partnerships and connections with local services. And so they can do that bridging and make those connections and really make sure that that family is wrapped around with services once they leave and are back in the community. Because again, the goal is for these families to be in their homes, in their safe environment. Next slide. So as Frank mentioned as well, we really wanted this opportunity to be a different experience than the ED. The feedback that we heard from families and stakeholders was that the ED was just developmentally not the place that we wanted youth who are experiencing mental health crises to be experiencing, with all the beeps and the medical things that are going on. And so the urgent crisis centers are really developmentally appropriate. You can see that the furniture is warm and inviting, the colors, the activities that are there. And this was really meant to set up a welcoming environment for youth and families to be able to de-escalate, approach the team that they're going to be met with, and be able to come up with a plan that is sustainable once they leave this environment. Next slide. So this has truly been a multi-agency implementation. DCF has partnered with many of our sister agencies in the promotion and build out of the urgent crisis centers. This has included working closely with the Department of Social Services to really develop some program-specific billing codes and fees. This is brand new here in the state of Connecticut, and so really working with them around Medicaid state plan amendments to make sure that this is something that's sustainable. We've also worked very closely with the Department of Public Health to really include some protocols and policies for ambulance drop-off. The goal will be to eventually have ambulance be able to divert rather than bringing youth to the emergency department, but bring them directly to an urgent crisis center if there is a mental health emergency. This has been done with the consultation of the Department of Public Health, and protocols for the ambulance have been sort of sent out preliminarily to really say that if they have the sponsorship of their hospital, and in consultation with their sponsor hospital, they can bring the ambulance can bring to the urgent crisis centers directly. We've also worked very closely with the Department of Education. The Department of Education, we anticipate, similar to our mobile crisis, will be our biggest word of mouth advertising, marketing, making sure that the families really know what's out there in terms of resources. So knowing that children are in school, we've really partnered with the Department of Education to promote and make sure that families are aware of this service. We've been able to work very closely with the superintendents. We've gone to special education directors as well as the school nurses. So really targeting some key stakeholders to make sure that they're aware of what this resource is and be able to share that with families. Next slide. So as this is very new, we are looking at the utilization. We're trying to track and make sure that we are making an impact. We want to know what the youth and family experience of care, the outcomes, and any systems issues that we are going to be facing. So as of now, when looking at our data since opening, which was around the summertime through the end of December, we have been able to see about 436 youth in our community urgent crisis centers across the 3 centers that we have that are in the community. 49% of those have been female and 47 have been male. And of that, the highest age range, 46% have been from 14 to 18, 33 have been from 10 to 13, 16, 6 to 9 years of age, and the smallest percentage at 5 was the 0 to 5 years old. The majority of those that were served by the community, like I said, were between the ages of 14 and 18. And when looking at the length of stay, typically most families are there between 3 and 5 hours. So going back to that comprehensive assessment and really developing a plan, it's taken about 3 to 5 hours. And episodes that were longer than that were very rare. And in terms of discharge, what we found is that over 90% of the youth that have been seen at UCCs were able to be safely discharged back to their home at the end of their episode. So again, this is information that we're continuing to track and look at, but that's some of the preliminary data that we've seen so far. Next slide. This is some of the information that we've heard from families. We've received a lot of testimonials. Each of our UCCs are actually asking families about their experience afterwards. And the words and themes that we've heard thus far is that families are feeling connected, they're feeling believed, calm, trusted, satisfied, motivated, and empowered. And I think the most wonderful thing is that families have really experienced this differently than when they have gone to an ED in the past. Next slide. So overall, we're hoping that this will improve the youth from having to not be seen at an emergency department when they don't need to. And Connecticut was actually fortunate enough to receive a TTI grant where we are going to be developing a performance improvement center with the hopes of really looking at what is the model that should be at these UCCs, synthesize some of the data, and develop a report of key indicators so that we can continue monitoring and assessing where we need to go with our urgent crisis centers. Next slide. And I think this is Frank.
So looking forward, we are also developing subacute crisis stabilization programs. We've got one that's come online and are in the process of developing another. And these are the next step, if you will, in this crisis continuum. They're intended to be very short term, but they're in recognition of those youth and families where, as actually the previous presenter presented with that slide that built out, if the youth is stabilized but the family constellation may still be in crisis. These are resources that can be in place for that. Again, with the intention to work very intensely with the youth and family to identify what supports and resources they need in order to be successful at home and to work to get those in place. And the gate, if you will, for the subacute will be essentially these other aspects of our care continuum. So mobile crisis, urgent crisis centers, our specialized outpatient clinics, as well as emergency departments and hospitals. So all with the intent to facilitate transition to home. Next slide. And I should say too that we do this, I should have mentioned in the beginning. So Department of Children and Families in Connecticut is the child welfare agency and also has statutory authority for the children's behavioral health system. We don't deliver most of our behavioral health services via state employees. We have a couple of facilities where that's the case, but all of the services we've been talking about are done through contract with a network of local private nonprofit provider agencies. So we really have an extensive array of resources. And when we get to question and answer, one of our providers is also on the phone with us here today, so they can jump in as well. So thank you, and I will now turn to Tennessee.
Thank you very much, Frank. Good afternoon, everyone. I'm Jennifer Armstrong. As I mentioned earlier, I'm to be the director of our Office of Crisis Services within the Division of Mental Health, here with Carrie Virgo, who you'll hear from shortly. But we're so excited to be here today. I'm always excited to speak to Tennessee's crisis system, but even more excited to speak to not only where we are with kids in our state, but where we are going with services. Next slide, please. All right, in terms of someone to call in Tennessee, we have 4 contracted provider agencies that have 24/7 crisis lines that are also our mobile crisis providers in our state. We have a Tennessee statewide crisis line across all 95 counties, and as both of the other states on this call, we have a 988 system that we contract with 7 provider agencies as well. In terms of someone to respond, as I mentioned, we have 4 mobile crisis response teams to provide that triage, risk assessment, and make the determination of the appropriate level of intervention and care. And then in terms of safe place to be, I'm really excited to talk about that because that is the current and the future forward vision for our state. We currently have one kids walk-in center CSU in East Tennessee, and we'll be talking with you on a little bit about the 2 new ones that we are proposing. This is an infographic on our website that I think does a really good job of outlining not only the sheer volume of those reaching out for help in our state, but the true diversionary efforts that our providers show in making sure that both adults and youth are met with appropriate level of resources at the appropriate time. So as you can see, for fiscal year 23, we had over 125,000 calls for help. And that again is for both adults and kids combined. But we had, of those calls, we had 53% resolved by the phone. So there was a lower level of intervention, whether it be a community mental health referral, consultation or something of that matter. We had 46% of those that were referred for mobile crisis because it was felt there was a higher level of intervention needed. In terms of the crisis assessments themselves, we had 73,052. 14,500 of those were for kids and young or youth, which makes up 19.6% of our total assessment volume. And then of those assessments completed, whether it be out in the community or in one of our walk-in centers, 66% were diverted from hospitalization, which is wonderful, with even a higher level specific to kids of 71%. Next slide. And I would be remiss. I know we're supposed to be focused on a safe place to be. We want to take 1 second just to kind of highlight what we're seeing the impact of our emergency department presentations and law enforcement involvement across all ages since the implementation of 988. We do not have, with a caveat, we do not have correlation data to specifically say this is because of the existence of 988, but we're seeing that it really is working as a diversionary resource upstream. So for fiscal year 23, compared to the prior 2 fiscal years, we're seeing an average decrease by 31 individuals a month presenting in an ER, which is great. We're seeing a decrease of 55 individuals per month that require law enforcement involvement. So I just wanted to highlight that, put that plug in there. We cannot be more excited about that resource being available in our state. Next slide. This is also on our website, but this is our map for current mobile crisis coverages. You can see, again, all 95 counties are covered across 4 providers. Next slide. Now, I don't have the really pretty pictures that Connecticut had, but I will next time we present. I can promise you that. So last fiscal year 23, we partnered with McNabb Center out of Knoxville and East Tennessee Children's Hospital to embed and co-locate walk-in center CSU on site at the hospital. And they just finished 1 full year. We're looking forward to seeing the outcomes this coming fiscal year. But within the walk-in center itself, they served ages 3 through 17, 1,452, with an 87% diversion rate from inpatient or residential treatment, which is wonderful. In terms of the CSU, 423 individuals were served ages 8 through 17. 35 admissions per month on average. Now, this is also when you talk about contract period and startup time, this is average when for several of those months was startup. So it would be even more, I know, if it were a full year. So this is still wonderful data. 4.8 days average length of stay, which I think really speaks to the robust up out of the gate care coordination, which I know that we see is a struggle sometimes. And then within the CSU, we saw a 95% diversion rate from inpatient and residential treatment. We do track recidivism, and I can certainly get that out. I just not had that available for this today, but I did recently get that information as well. I will say it's fairly low, but I don't have the exact percentage. Next slide. All right, so children and youth crisis services expansion. Our governor, we're so grateful, provided funding to allow for regional coverage for kids CSU. Again, this is new in Tennessee, but we are going to be adding a CSU in West Tennessee, a CSU in Middle Tennessee, and help sustain the operations of the CSU in East Tennessee. will serve ages 4 through 17, providing that regional coverage. With walk-in center services to include, I believe someone mentioned earlier, not only the obviously crisis assessment, but that 23 observation if that is needed on site, and then have the ability to refer to the crisis stabilization unit, which will serve up to 5 days. We are looking at, based on the great work that the McNabb Center in Knoxville's done, we're going to be looking at replicating a lot of what they already capture, but really focusing on not only volume, length of stay, but more quality level data for around things like diversion, discharge, disposition, rate of return to crisis, recidivism, and with discharge disposition, looking at how effective were services were the youth ultimately able to be referred home, and looking at service linkage, looking at maintenance in services as well. Next slide. And at this time, I'm going to turn it over to our Deputy Assistant Commissioner, Carrie Virgo, with the Division of Kids.
Thanks, Jen. Super excited to talk to y'all a little bit about some of the things that we have decided to try and see what would work in terms of taking the crisis continuum past mobile crisis. And so currently we have a few specialty projects that we're working on in the state of Tennessee. One of those being the Tennessee Resiliency Project. This was funded by a state appropriation from the General Assembly and Governor Lee in FY22. And what this particular project did was allowed providers to tell us where the gaps were in their system. What did they see as the needs in their communities? And they were allowed to choose from 3 areas. They could either work in infant and early childhood, school-based services, or in the crisis continuum. 5 of those projects are based on the crisis continuum. We're running a little short on time, so I'm not going to get too detailed, but if you want to know more, please reach out. One of our teams in East Tennessee has specialized crisis teams. They have a crisis team specifically devoted to detention centers and one specifically devoted to the schools, which has actually been very helpful for both of those particular systems. The other one that I really want to talk about is we also have a hard to place team. So Youth Villages is one of our providers, and they actually have hired 5 crisis coordinators who are specifically looking at those hard to place kids. So those that are in need of hospitalization and we're having difficulty with insurance or things like that. That team is specifically designed to address those children. Our other specialty project is we also received a TTI, Transformation Transfer Initiative. And in FY22, we decided to focus on 2 particular emergency departments. I'm going to go into that in the slides here in just a second. And then our last specialty project is the Bipartisan Safer Communities Act. We had had such great success with the Resiliency Project being able to embed mental health clinicians into primary care offices that we were able to expand that further under the Bipartisan Safer Communities Act and add additional community mental health centers who've embedded therapists into primary care offices. Next slide, please. One of our TTI projects in FY22 was also at the McNabb Center in East Tennessee Children's Hospital. As they were building out their CSU, this was one of the things that we did in the interim. And what that project did was embed a master's level clinician into the emergency department to do on-site assessment and medication consultation. They were paired with a peer support for system navigation. So they were also able to make sure that the referrals were in place. The significant piece of this is that wait times were reduced by an average of 10 hours, and they saw a 56% diversion rate from higher levels of care. Next slide. This particular part of the transformation transfer initiative, you're actually going to get to hear from the family support specialist here in a second. We've got that video for y'all. they are really doing intensive care coordination at the door in the emergency department. They are meeting with families on the spot to talk about what does your family need to help you be successful. It is really hard to navigate the mental health system, and we want to make sure that our families feel empowered and know where to go and where to get the services and supports that they need. Next slide. This has been so incredibly successful that it has launched a lot of things here in Tennessee. From August of 22 to December 23, they had done 554 assessments in the emergency department at Monroe Carroll. They had 696 follow-ups. So you can see they had multiple different referrals out to different services and had those follow-up appointments. In addition, I can tell you with so much excitement that we were able to reduce the return to the emergency department from 15% to 3%. And that's within the first month of discharge. Overall, for all of those who've been assessed, only 4% have returned to the emergency department for additional services. 61% of those families that were assessed either attended or planned to attend a future appointment. What we know is that when people walk out the door, whether that be from juvenile court, emergency departments, there's a gap. And sometimes they fall in that gap where they were referred to services, but they don't go for whatever reason. What we are trying to do here is provide enhanced follow-up services to make sure that these families are getting to the next place. There's a lot going on when they're presenting to an emergency department, and sometimes it can just be overwhelming to the point that they just kind of give up or choose that maybe I can address this some other way and don't attend those future appointments. And then we see a lot of the times them returning to the emergency department. So this was really our attempt to make sure that families got what they need when they left, so they never had to return to the emergency department. And I think we're getting really good at meeting that goal. Next slide. I do want to share with y'all just real fast. This is Dawn Mitchell. She is our family support specialist that's embedded at Monroe Carroll Junior Children's Hospital here in Nashville. If you play that slide, please.
I'm Dawn Mitchell, and I work for Mental Health Cooperative embedded at Vanderbilt Children's Hospital in their emergency department. Serving kids and families when they come into the emergency room in a crisis at times is a challenge, and it's rewarding because families who come in a crisis they feel like the hospital is their last hope. And then when they are connected with community services and resources are provided, they realize that they can become healthy in their community. So when we help them in the emergency department, we are beginning to change a trajectory, because providing community resources and information and supports that are available really begin to empower them and offer them the knowledge, which begins to change the trajectory of the sense of hopelessness to a sense of hope. And instead of coming from a place of being a victim, they come to a place of coming from victory, because they've already began to win the battle that they were experiencing.
How long have you been a certified family support specialist?
When did they do the original certification? So I was number 6. What made me want to do it are the challenges that my family experienced when we first embarked on the mental health and behavioral health portion of our sons' lives, trying to obtain resources with private insurance, knocking down doors, trying to get someone to hear what you're saying, and learning that it's not a criminal behavior, it's a mental health crisis. That's what allowed me to come in to do that. For some families who have had repeated crises, for them to continue to walk and struggle and just feel hopeless and defeated is a place where many parents have been throughout the United States. But here in Tennessee, we're the volunteer state. We just volunteer to walk along folks and to empower them and to encourage them. and to offer them knowledge so that when they're making decisions, they're making informed decisions based off of the need of their family. It takes a village for all of us to love on each other. And if I had not had the opportunity and the folks that I had over, well, almost 30 years ago now, I would not be where I am today, where I can provide hope and support and love and just hug a mom. And sometimes that's what moms need. We just need hugs. We just need someone to say, I've got you for this 1 minute.
Thank you so much for letting me share that with you. You can go to the next slide. We're already over time, so I'm gonna end and hand it back to David. And if you have any questions, let us know. Thank you.
Thank you so much. It's always great to hear that lived experience voice and really brings the message home. Thanks to all six of you. What great presentations. And I also want to say a big thank you because you guys have really been doing a good job of keeping up with the questions in the chat. So appreciate the presenters taking them one by one. And I think there's only one that I see that maybe wasn't asked, and I will ask it to all three states. Someone wanted to know if anybody on your teams have IDD or autism background and training.
I can speak for Connecticut. We have provided that as specialty training for the staff of the centers. We recognize that that's very different than having staff with particular expertise. And so that's an ongoing conversation that we're having and with our Department of Developmental Services, not only for this program, but actually across our service system for how to make the array of services, particularly community-based services, authentically available to youth with IDD or on the autism spectrum. So I would say it's work in progress.
Yeah, and we've had people come in to do training. And so, like you, it's a work in progress. And that is a population that tends to, get stuck in crisis systems. And we do have peers who, some of them have family members, like they have a child on, with IDD. And so sometimes we found that when we have kids with those challenges, that pairing that peer with that youth often is really helpful because their lived experience as a parent, they're uniquely suited to that. But then we also have to be mindful of not burning them out and rotating them off, especially when we have youth that sometimes get stuck with us for a while.
And I will ditto in terms of the training from both of the other states. We do have through our DIDD, Department of Developmental and Intellectual Disabilities, a new program that right now is specific to adults, but it's called a START team. And they are actually phasing in to do co-response with our adult mobile crisis teams, which is wonderful. That is our ultimate goal, is to get that involved in terms, with our youth as well, but we're just not there yet.
And in Tennessee, we will. Oh, sorry, David.
No, go ahead.
I was just going to say also in Tennessee, our family support specialist program, we are actually in the process of redoing some of our curriculum. We will now be certifying parents and caregivers who have a child on the autism spectrum. So we will be doing lots more specialized training just to make sure that we completely understand the population and are providing the right types of services.
Great, thank you. We have about 10 minutes for other questions. And so if you have a question, please pop it in the chat box. We will, after at 10 of, we're gonna stop recording. We're gonna go to sort of a just us chickens talking, where y'all can talk directly to the six presenters today, and it won't be recorded. So, but if you have any questions, please pop them in. I have a question, just knowing, and I know Carrie knows this because she's our chair of our Nashville's Children's Youth and Family Division, and I see more and more of our folks trying to do more in collaboration with child welfare, knowing that those agencies and those services are completely aligned here. What have y'all been able to do or see in sort of a trending moving forward of trying to pull child welfare better in and have sort of similar communication and languages and sort of kind of breaking down the silos? Or have you seen an effort from child welfare wanting to be part of that conversation?
I say from a provider standpoint, I mean, we get a lot of kids in DC, we call it DCS in Arizona. We have a lot of kids in DCS custody, and placement is a hugely important issue. And so we were like, well, we need to be working on this with them right off the bat. And we found that just trying to like call their individual case managers, like through the course of the youth stay, really wasn't working that well because they're out in the field doing stuff, and we couldn't get a hold of them. And so we proactively set up a daily call with kind of their management level, one level up, so that and it's scheduled and it happens every day. So it's like, okay, these are the kids that we have, these are the barriers that we anticipate, and so that we can really just be proactive in working with them.
Great.
I'll let Carrie speak to in terms of the hard to place youth at youth villages, but I will say we have a very close relationship with our state Medicaid director over what we call 10 Care, and we're he was very involved. And so if we do have a situation where there is a hard to place youth, the first thing that we do is schedule a call with DCS and with 10 Care and the provider to help try to coordinate efforts and make sure everybody is in line. And like you said, and the communication is consistent. Oftentimes it's the miscommunication is we found to be the missing link. But we recently worked with 10 Care to create a coordination of care policy to indicate at what point our providers need to go ahead and reach out and pull them in and what that process needs to look like. So that's been helpful. I mean, that's only been probably live for the last 6 months.
And in Connecticut, as I said, we are an integrated agency. So we have child welfare and children's behavioral health under one roof, as it were. And we have all the benefits and challenges of families who are in one place together, I guess you'd say. But even more specifically, one of the things we've been looking at, we looked recently at the youth who needed to come into state custody on an emergency basis. And a significant percentage, about 2/3, were youth who had been in emergency departments, often for behavioral health crisis, whose families said, we can't take them home, we can't do this. And so really, one of the things that having both systems together has enabled us to do is to really be able to look at it from different angles and recognize where in one part of the system something is emerging, that in the other part of the system we can try to be responsive to. So anyway, we're under one roof.
Great, thank you. There was a question about TBI and whether or not you all were screening for TBI on your teams.
We are actually in the process of finalizing a workflow specific to 988, where they can hand off certain cases to our teams. We're very close to finalizing that. And outside of that, we do provide consultation in certain scenarios for TBI, but nothing formal other than this workflow and process.
Yeah, it's part of our psychiatric assessment. And then we work on a treatment plan, based on what we know about them.
I'd say the same. Each youth coming in, at least on the urgent crisis center, would be seen by a nurse and at their discretion, a physician, so they could assess them in that way. But we don't have within the crisis continuum a specialty service, if you will.
Great. There's a question in your safe places to be, how do you prevent boarding in situations where the youth needs to be hospitalized or there's a wait list? Easy answer. I mean, I know this is an easy question. Everybody probably wants to take a swing at this one.
Well, I mean, that does happen. And first of all, our philosophy is we'll better be boarding in a specialized youth treatment facility than an ED. And then, so, you know, that's an improvement right off the bat, even though you don't want anybody boarding. And then we, every day are, first of all, we're continuing treatment and we're trying to get them better. So we're not just going, oh, like if they were in an ED, they would just basically be waiting. And the end point is whenever they get a hospital bed, where we're still continuing to try to get them stabilized and work on placements that are not the hospital. And then, you know, we work with our, like I sometimes call our regional behavioral health authority, our benevolent overlords, because, you know, we reach out to them for help in their health plan. And, you know, it's like you know, this individual that you're responsible for is stuck. How can you help us figure out how to, you know, get them what they need? You know, we have good relationships with the hospital. So before we get to that level, you know, we've got our management talking to hospital management and, you know, trying to work out things. And then, like I said, the best prevention for that though, is kind of with that funky graph where the more levels of care you have in between home and the hospital, the less you have to default to the hospital.
I will say for Tennessee, the fact that we are adding walk-in center CSUs is going to automatically help us to some capacity, because right now, you know, the stop between mobile crisis, if they need a higher level of care, is inpatient. So I'm excited to see the impact of that here. The other thing I will say is in early 2020, our medical director created medication protocols and started meeting with hospitals across the state, so that like you mentioned, we can start treatment in-house instead of them just sitting there. We want something to be occurring. And oftentimes when that happens, they're able to be discharged back home. So that's been very helpful in Tennessee.
Great. There's a question for the bed-based crisis stabilization service. I understood that some serve adults, even some in the same building. What are the differences in programming model, facility staffing, et cetera, between bed-based service for kids and adults? And is information on the models that's being used for kids, you know, like again, programming, facility standards, staffing, et cetera, for these units publicly available?
Well, first of all, the kids and the adults never mix. So, and ours are in the same building, but you come into like an unlicensed atrium and it's youth on one side and adults on the other. So they have their own waiting rooms and all that kind of stuff.